Good morning, everyone. This is April the 16th, 2014, regular health board meeting. Does everyone have an agenda? All right. Give me a roll call, please.
Bill Taylor, Tommy Snoop, Perry Shell, David Wool,
here.
Toonie Crow,
He's excused. Albert's sitting in for Toonie.
Brandon Jones,
Here.
Charlotte Taylor,
Here.
Tashina Parker, Albert Crow,
Pam Strong sitting in for Albert.
Vicky Bradley,
Here.
Barb Jones.
Here.
All right. Is there any changes to the agenda?
No.
Okay. First on the agenda have solid care report. David Hunt. Good morning, Dave.
Hey, good morning. I hope each of you have a copy of the report in front of you. As you'll see, again, the census is a little bit low. That is, as you know, we've been talking about, that is intentional. The floor project, in order to get those vendors in and out, we had to do that. We did have we did find moisture problems in the slab, so we had to do some additional treatments there. We have not actually started tearing the floors up. That will begin tomorrow morning at 9 a.m. However, while the moisture problems that we discovered in the slab delayed us about 2 weeks because of the treatment that had to be done to the tile. When it arrives, it'll be a peel and stick process, so we'll pick up that time on the back end. We'll complete the room project at the same time, and so we should bring our census back up pretty quickly. We should be done with the rooms in about 5 weeks, and then it'll take probably another 3 to 4 weeks to finish the hallways and the common areas. But we are excited about that. We have also, and I want to say thank you, I guess publicly, to Chris Green and Mr. Lambert, Damon Lambert, working with us. They've helped us a lot. Actually ended up saving quite a bit of money on the wall project. We're going to have a nice, excellent looking covering on the walls, and we've saved from the projections that the material that we were initially going to use. I think this will end up looking better. It's going to go quicker, and it saved quite a bit of money. So appreciate them doing that and working with me. They always are a big help. And that project will begin almost immediately as soon as this one finishes. We plan on having both of them. We're aggressive time frame would be before July 4th holiday. We'll have both projects complete, and you know, the elders down there are excited about what their new home's going to look like, and certainly want to extend their thanks to the health board, the council, and to executive for all the support. Of course, that affects, you know, obviously reimbursements. However, you know, as you can see, we're still on track to approach $5.5 million in revenue. We hope that will occur. Of course, with the reduction in census, it's going to push it, but we should come close if we can get those beds up and back up in the next 5 weeks or so, and start filling them back up. I know your constituents. I don't know if you've had calls for people saying that they, you know, couldn't get placed. Again, it's just something that we had to do, because if those beds were full, as we've talked about, you know, we would have to, it takes about 2 days to complete the project, and we have to have, you know, they have to have a proper room for them to stay in. I mean, obviously you're well aware, and I hope the community does. I'm just repeating that so that people understand, and we appreciate your patience. But we can't, you know, allow people to sleep in the hallway or in common areas like a day room or a dining room. But anyway, you know, as we move forward and get that back on, then the census should go back up, and of course, obviously, revenues will follow. Facility issues. Well, we've already talked about those. We do have something that, you know, Vicky stresses all the time about looking for quality and making sure that we're meeting the needs of the community what the community wants and their expectations. And so we are starting, as part of our quality improvement projects, we're going to be contracting with a third-party vendor. The one that I'm going to recommend is a company is called My Interview, and they do quality surveys with about 5,000 long-term care facilities nationwide. So that allows us to benchmark, not only to get feedback from this community, specifically what do they want, but it also allows us to take a look at, how do we compare to other facilities, not just financially, but in all areas of care, because that's something that, of course, is expected from you as well as Vicki, and so we hope that that'll give us some guidance, further guidance into exactly what the community wants and how we stack up to all the other facilities in the nation, because we want to be prepared, for the regulatory process as well. Other than that, we do have a few vacancies, and in the personnel issues, one of the things that I have not addressed here, of course, we are looking at. We've been asked to take a look at the equity. I guess the equity pay, the equity structure, and I guess all programs will be doing that. We have received back now all of our job descriptions and where all of that fell out, and taking a look at that as well, making some recommendations, I guess, here to Vicki and to executive also for those final moves if and when necessary.
Any questions for David? All right. Looks like the project's moving well, and I know the residents are probably excited to see a new.
They are. They're very excited.
Some new renovations down there.
So.
No questions for David. All right. Good report, David.
All right. Thank you.
Next on the agenda, have Vicki Bradley, Department of Health and Human Service update.
Good morning, Health Board. I'm going to forego our regular report in the interest of time today because we do have a special guest, Ms. Liz Malerba, who will be presenting a little bit later. But we do have 2 IRB requests, and we have Dr. Turner Goings. I'm going to ask Turner to present her IRB request. It has been fully approved by the Medical IRB Board, and just wanted to give you a heads up that resolution will be coming forth in May to the Tribal Council.
$10 minutes or so, or 5 minutes? Okay. Good morning, I'm Turner Goins. I've been working with the tribe since '99 on elder health-related issues and with respect to research. We did the Cherokee Elder Care Study back in 06-08, where we interviewed 505 tribal elders in the 5-county service area. And this morning I am presenting this study that has received medical IRB approval. It's a project entitled Mental Health and Diabetes Among Older American Indians. So this issue, so how does this issue emerge? This issue came from the conversations with tribal leaders in the health area at the tribe, and identifying diabetes and mental health as being 2 big issues among the older members of the tribe. So through these conversations, we submitted a grant with support from the Public Health and Human Services Office of Vicki Bradley. I had letters of support from Vicki, Casey Cooper, Dr. Ann Bullock, and Blythe Winchester, Dr. Blythe Winchester. This grant was submitted in summer of 2012, so this is how quick the National Institutes of Health works. We just got notification this fall that it was funded. This grant was submitted with the Native American Research Centers for Health grant application from USET and Vanderbilt University School of Medicine. So we received a notification this fall that it was funded by the National Institutes of Health. It's a 4-year grant, started September 15th of 2013, and it goes through September of 2017. The total award was $421,846, with approximately $89,000 coming to the tribe. The bulk of those monies are going to the hospital to support Jim Eller for his assistance. There is an advisory committee that's made up of predominantly all tribal members. It consists of, Vicki Bradley, Casey Cooper, Dr. Ann Bullock, Dr. Blythe Winchester, and Jim Eller. So the overall objective of this study was to look at the relationship between mental health and diabetes outcomes with respect to control management and complications, and also trying to look at the role in which social support plays. In particular, there's three aims: looking at the association between mental health and diabetes control, and seeing if it's modified by social support; looking at the association between mental health and diabetes-related complications, again, seeing if social support modifies that relationship; and then third, looking at perceived factors of older tribal members in terms of their beliefs around what contributes to good diabetes control and management. As I mentioned earlier, this project is building on the Cherokee Elder Care Study. It was conducted in 06-08. Participants were enrolled members that resided in the 5-county service area. The study, we interviewed 505 enrolled members. They were aged 55 years and over at that time, so this population is now at least 63 years old. And again, they resided in the tribal service area. In terms of methods, with the elder care study data, which was survey data, the idea is to link their data to their hospital data with respect to diabetes and mental health. This is Jim Eller's role, since he's an employee of the hospital and this is his expertise. The idea would be that Jim would link the survey data to the hospital data, and once they're linked, they'll be de-identified. So I won't have access to any information of individual information, and then he will send me the data set de-identified that's linked to the hospital data and the survey data. The Cherokee Elder Care Study data from there, we will be looking at their demographic characteristics, age, sex, marital status, whether they lived alone or not. We asked questions on depressive symptomatology and traumatic experience and symptoms related to traumatic experience if they had one, as well as social support. And the hospital data we are wanting to look at is diagnosed diabetes type 2 diabetes, diabetes-related complications, all these related conditions: retinopathy, nephropathy, cardiovascular disease, peripheral vascular disease, cerebrovascular disease, cholesterol, amputations, mortality, A1C levels, blood pressure, and mental health diagnosis and mental health related prescription medications. The third aim, in terms of perceptions of what constitutes good diabetes control, this will involve soliciting participants for an interview. The first two objectives is just analyzing existing data. This aim would be sending a letter out to persons from the Cherokee Elder Care Study cohort, not from me, but from within the hospital system, asking them if they'd be interested, and if they are, then they would contact me. And they could call me on a toll-free number if they're willing to participate, interested to participate. I estimate it'll be about an hour interview. They'll be compensated for their time, $75. And we'll do the interviews in their home. If they'd rather do it somewhere else, we would accommodate them in another location. So that's, in a nutshell, the study and the methods.
Any questions for Turner, Perry?
Yeah, two things. Could I get a copy of your presentation that you just gave? And
sure.
Also, what is considered elder?
Well,
what age group are you using or what are the participants in this survey?
Well, the Cherokee Elder Care Study, when we first approached the tribe, when I first approached the tribe to do this study, I was looking at 65 years and over, but based on consultation and input from tribal leaders, it was suggested that we drop it down to 55 years and over, primarily because a lot of health conditions that we see, typically see in older adults, occurs unfortunately at younger ages often in the community. So we dropped the age down to 55 years and over. And since this study is based on that cohort now is at least age 63. Yeah.
Any other questions, Albert?
I'd like to get a copy too, if you don't mind.
Sure. What's the easiest way to get you a copy of the presentation? I didn't bring hard copies.
There's a box out there, you know.
Okay.
Yeah.
Okay.
I'll go there.
If you'll email it to me,
Okay.
I'll make sure they get it.
Sure. Yeah. Yeah.
So you're going to use the elder study, the same population?
Yes. That's the idea, is to look at that population a little further with respect to mental health and diabetes outcomes.
So this was already approved. This was already approved by the medical. Yeah, I move we approve this survey.
All right. Perry's got a move on the floor to endorse this with this board. All right. All in favor? All right.
All right. Well, thank you for your time.
Thank you.
You had to participate in the Cherokee Elder Care Study.
Mr. Chairman, the second medical IRB approval that was presented this month and was approved is for Dr. Joan O'Connell, and I'm just going to read you briefly from the resolution that was presented to TEOC and signed in. So Dr. O'Connell is from the University of Denver. The tribe's medical IRB has been assigned the task of reviewing research requests made to the Eastern Band, and in 2012 the tribe approved the initial study entitled Comparative Effectiveness of Healthcare Delivery Systems for American Indians and Alaska Natives, and the study concluded that the prevalence of cardiovascular disease in adults with diabetes was higher than expected, and whereas the medical IRB has reviewed and approved a research request on March the 26th, 2014 made by Dr. Joan O'Connell of the University of Colorado, Denver, School of Public Health, Center for American Indian and Alaska Native, to conduct a second phase study entitled Comparative Effectiveness of Healthcare Delivery Systems for American Indians and Alaska Natives, also known as the Indian Health Service Improving Healthcare Delivery Data Project. The purpose of this study is to conduct detailed analysis of health status, service utilization, and treatment costs for patients with both diabetes and cardiovascular disease, and to improve health outcomes and reduce documented disparities by informing the management of diabetes and the provision for cost-effective care. This was reviewed. Dr. O'Connell primarily works in the Cherokee Indian Hospital System and through RPMS. I don't know if Casey has any comments about the usefulness of the first phase. This is a study that we were selected out of a number of tribes across the country to participate in. It was helpful for us, and it's also helpful for cost forecasting for the care of diabetes and cardiovascular disease, which we know are two of our top diagnoses. And after thorough review of the medical IRB, I accept their recommendation and propose to the board that we also endorse Dr. Joan O'Connell's recommendation or her IRB request and forward that on in resolution form to the tribal council.
All right, got a move to endorse Dr. Joan O'Connell's request, survey request. Got a second on that move? Second. Got a move and a second. All in favor? Unanimous by the members present.
And if we could delete the healthy foods policy in reviewing the minutes, which, thank you, that's very helpful. We did bring that forth last month in Health Board, and so I will defer the rest of my time to Mr. Casey Cooper for his presentations, and then also to Ms. Liz Malerba.
Okay, thank you. Casey?
Mr. Chairman, I would also ask that Trina Al sit in for me for the remainder of the meeting.
That'll be fine.
Thank you.
Thank you, Mr. Chairman, and good morning, Health Board. In my presentation this morning, I will spend some time talking to you a little bit about the new hospital and some behavioral health services. But before I do that, I would like to introduce a guest speaker to you, Liz Malerba, who is a member of the Mohegan tribe and works for USET. And Liz has been traveling all over the country for the past year teaching people about the Indian provisions in the Affordable Care Act. Has been here now, this is her third time here in the community. She came before USET, the last USET meeting, and did a really good 2-day educational session for us. And then we had asked her, subsequent to the last USET meeting, or subsequent to Impact Week, to come back and to help us communicate to the community a little bit more accurately accurately some elements that are real important, primarily the lifetime exemption for American Indians, Alaska Natives, and then talk to you a little bit about corporate sponsorship as she talks to you about all of the Indian provisions in the Affordable Care Act. So at this time, I'd like to introduce Liz Malerba.
Welcome, Liz.
Thank you, Mr. Chairman. I'm really excited to be here in beautiful Cherokee again. It's always nice to escape Washington, D.C. I'm USET's health policy analyst mostly, although I do a few other things as well. And I'm USET's only staffer that's based in D.C. So whenever you're in D.C., please feel free to drop by our office. It's not just a little closet. We do have we have actual facilities, and so if you ever need to conduct a meeting or need any technical support while you're in town, please feel free to contact me. I've worked for USET now for about 2 years. It'll be 2 years in May. Before that, I did about 1.5 years worth of legislative work for the National Indian Health Board. And prior to that, I spent about 3 years on Capitol Hill. So I've spent way too much time in D.C. Hopefully, I will someday return to my home tribe, the Mohegan tribe in Connecticut. But for now, I belong to USET and by extension, Cherokee. So let me pass out my presentation. Casey will do that for me. Thank you so much. I apologize for the format. I got a brand new printer in my office, and because it's just little old me, I'm having, I guess, a little technical difficulty making it work. So, but all the information is in there. Just waiting for my presentation to load. Doesn't like my... There we go. So I'm here today to talk to you guys a little bit about the Affordable Care Act and the special provisions that it contains for American Indians and Alaska Natives. I'm also going to talk a little bit, as Casey said, about the concept of tribal sponsorship under this law. That is the tribe actually paying insurance premiums and assisting folks in enrolling in Medicaid in order to, one, insure your population, and two, reap the benefits of that, which is being able to third-party bill for the services that you already provide to your tribal members. When we're talking about tribal sponsorship, we can't forget what the law hinges on, which is the individual mandate, the requirement that most Americans have some form of insurance, whether that be private insurance or public insurance, employer-based insurance, or VA benefits. Thank you. And so I wanted to touch a little bit on the IRS provisions, and then I'm going to wrap up by talking about Indian exemptions and other exemptions that might be helpful to those folks who, just for whatever reason, aren't interested in enrolling in an insurance plan. So as you know, the Patient Protection and Affordable Care Act was enacted March 23rd of 2010. That means the federal government has been spending about the last 4 years implementing the law, for better or worse. I'm sure you're aware of kind of all the hiccups that have happened along the way. What the Affordable Care Act has in it, in a nutshell, is namely insurance reforms. That means no lifetime limits or annual limits for coverage for people. And also now, for the first time, insurance companies are required to cover anybody who applies for coverage regardless of any pre-existing conditions. Previously, insurance companies could deny you coverage based on a chronic condition you may have had in the past and for all intents and purposes had been resolved, or a chronic condition that continued. They could discriminate against gender, charging women more for care and coverage than men. The law also contains an expansion of the Medicaid program, although we'll talk a little bit about why that's not happening in North Carolina. I'll touch on that. It contains the implementation of health insurance exchanges. And when I say health insurance exchange, I mean a website where people can look at insurance plans at a particular level of coverage and compare and contrast the benefits and the costs of those plans. So it's similar to something, say like a kayak, where you can take a look at various airline prices, or a website where you can compare the cost of a hotel room. It really serves to provide transparency in the cost of insurance, because previously it would have taken a lot of digging for an individual to figure out kind of what the differences are in insurance plans based on costs and covered benefits. And it creates these health insurance exchanges, or marketplaces, as they're now known, for both individuals, people who are shopping for just insurance coverage for themselves, and small businesses. So when we say small business, we mean less than 25 people or 50 people. And these small businesses can also go onto their own exchanges and shop for coverage for their employees. It makes some changes to the Medicare Part D program, ultimately attempting to close the donut hole. If you're familiar with Medicare Part D, an unintended consequence of the law was what's known as the donut hole, where a senior would have Medicare Part D coverage up to a certain amount. Then they would be forced to pay for coverage until they hit another higher threshold, and the law closes that. And over the past few years, CMS has actually been providing reimbursement checks to elders as part of Medicare Part D donut hole closure. It focuses and rewards quality, prevention, and innovation. There are some provisions related to the healthcare workforce. And importantly for tribes, it also includes the permanent reauthorization of the Indian Healthcare Improvement Act, which I'm sure, as you know, is the statutory authority for IHS and tribes to actually do their work. So ultimately what the law does is it seeks to reduce the number of uninsured people in America. And it does this by removing barriers to the purchase of insurance. So it reforms insurance, as I said, mostly in terms of pre-existing conditions and lifetime and annual limits. It expands Medicaid, so for very low income folks who may not previously have had access to Medicaid in certain states, they'll now be covered through the Medicaid program. It creates these new market structures, the exchanges in each state, or marketplaces, as we're now calling them. And then also it reforms the insurance that's offered outside of the marketplace, off the website, including making sure that they're covering folks with pre-existing conditions, and also give folks plans with an array of essential health benefits that we'll talk about. It also includes some risk reduction for insurance companies, and so the law kind of levels the playing field for those insurance companies who take on more risk, and those insurance companies who, for whatever reason, may practice adverse selection to take on less risk. So each year, at the end of the year, insurance companies are kind of leveled off, made whole again, for taking on this, chronically ill population that they may not have wanted to take on previously. More strategies to reduce uninsured are what we like to call kind of carrots and sticks, provisions that both entice folks to purchase care, and provisions that kind of, frighten them into purchasing care. In all honesty. And the carrots include premium assistance from the federal government for individuals under 400% of the federal poverty level. That is, the federal government will actually give you a tax credit to help you purchase insurance coverage for yourself and your family. And then also federal tax credits for very small businesses that have less than 25 employees, to provide employer-based care to their employees. And then, the sticks, as we well know, are the tax penalty for not being insured, the individual mandate. That's been, a major topic of conversation, although it seems to be slowing down, I think. And I'll talk about the fact that American Indians and Alaska Natives are exempt from the individual mandate. But there is a process that you have to go through to achieve this exemption, and we're gonna discuss that in detail. And then any business with greater than 50 employees is actually required to offer affordable coverage to their employees. And if they choose not to do that, then they're fined $2,000 per person over 30 people that they employ. why is the law important to us as the people who provide health care to American Indians and Alaska Natives across the country? For the first time, there's a single enrollment form available to people who are interested in coverage. And so you can use one form to enroll in Medicaid. In Medicaid expansion, if your state expands, the Children's Health Insurance Program, and also these plans that are offered on the exchange or marketplace. There are new sources of funding for enrollment. As I said, the exchanges are available. They cover all adults that are younger than the age of 65. Folks who are older than the age of 65 do have access to the health insurance exchanges or marketplaces. However, if you're eligible for Medicare, you're not eligible to receive the premium assistance that would help you purchase the plan because they really want you to stay on Medicare. There is premium assistance, as I said, up to 400% of federal poverty level, and we'll talk about what that looks like. Importantly for Cherokee and for other tribes across the country, when more of your citizens are insured, when more of your patients are insured, you're able to build the insurance plan and recoup some of the costs of providing care to those individuals and also even make money. And this actually shifts the cost of contract health services, now known as purchased and referred care. If you haven't heard, IHS changed that. Great. It shifts the cost of CHS onto insurance plans instead of onto your CHS program. And Medicaid expansion, we're still hopeful that North Carolina might choose to expand Medicaid. Medicaid expansion for those states who have expanded is up to 138% of the federal poverty level. The law says 133%, but what Medicaid does is it practices a 5% income disregard, moving that threshold up to 138%. And this just prevents people from kind of popping on and off of Medicaid at very low income levels. To qualify for Medicaid, your assets aren't counted, it's just your income. And for the first time in Medicaid expansion states, Medicaid covers all adults. And so this means adults without children in the home. Very often, adults are only eligible for Medicaid when they have small children. So again, what is a health insurance exchange or marketplace? What am I talking about? Consumers and businesses can compare insurance plans and purchase them on this website. The marketplace also provides, helps assist with the federal subsidies of premiums. The money actually comes in the form of a tax credit from IRS, but the marketplace facilitates the subsidy of the premiums. You can enroll in Medicaid and CHIP. It's a web-based approach, as I said, and there are different types of marketplaces. Some states have chosen to operate their own marketplaces, and those states who haven't chosen to do that are operating under the federal government's marketplace, and of course North Carolina is a federally operated marketplace. What does the exchange do? What does the marketplace do? It actually selects the plans that will be offered. It assists with enrollment, meaning it determines what an individual is eligible for, whether they're eligible for Medicaid or CHIP, or whether they're eligible for a tax credit. It actually enrolls the people who are using the online system in the qualified health plans or a multi-state plan. It has call centers to assist people either in enrolling online or for folks who don't have access to the internet or for whatever reason aren't particularly internet savvy. Those folks can call the call center and receive assistance over the telephone. Although I will add one caveat to that. The call center staff is not all that well versed in American Indian and Alaska Native issues and with our health system and even with some of the special provisions in the law. So I would caution sending lots of people to the call center. The exchange or marketplace also contracts with navigators and assisters, and those folks actually also help do enrollment. They help people enroll in person. So that's another feature that can be used for folks who may not be particularly internet savvy or may not have access. It determines who is exempt from the tax penalties, and again, we're going to talk a lot about that. And then it manages all the financial aspects of the insurance plans and of the law in general, the premiums, the tax credits, cost sharing features, and risk adjustments for the insurance companies. The exchange or marketplace offers a number of different metallic plans. All plans have the same essential health benefits, and I'll show you a list of what exactly that means. But plans may differ in their networks of providers and the cost of premiums, copays, and deductibles. Actuarial values of plans are what is used to kind of distinguish between the types of plans offered. So there's bronze, which is a 60% actuarial value, all the way up to, well, the law authorizes platinum at a 90% actuarial value, but none of the insurance companies seem to want to offer platinum plans because they don't think anybody wants to purchase that type of a plan. And when I'm talking about actuarial value, what I mean is the percentage of total average costs for covered benefits that a plan will pay. So for example, if you buy an insurance plan with an actuarial value of 60%, on an average year, you're responsible for paying 40% of the associated costs. And in any given year, you might have to pay a little bit higher, a little bit lower percentage of the costs, depending on your healthcare needs that year and the terms of your insurance policy. However, enrolled members of the tribe don't have to pay cost sharing in most cases, and we'll talk a little bit about that. Again, when I'm talking about essential health benefits, I'm talking about this array of services. A major part of the law is that all insurance plans, with the exception of a very few, have to cover all of these services, including ambulatory patient services, emergency services, hospitalization, maternity and newborn care, behavioral health treatment, prescription drugs, rehabilitative and habilitative services, laboratory services, preventive and wellness services, including chronic disease management, and then also pediatric, including oral and vision. Pediatric means less than the age of 19, usually. And those folks are the ones that get oral and vision as part of their plans without additional costs. There are things like standalone dental and vision plans that are offered through the marketplaces, but if you're not a pediatric person, then you're having to pay additional for that. Why are the essential benefits important for tribes? These are the covered services that you can be paid to deliver to people who are enrolled in health insurance plans that you're already treating. So the reimbursement from the health insurance plan and the tax credits that are given to folks to help them purchase their plans, they're only limited to services that are included in essential health benefits. So you're not going to get a tax credit to purchase, to get LASIK eye surgery, for example, or plastic surgery. The tax credits are limited just to those essential health benefits. There are separate premium calculations for plans that include non-essential health benefits, but for the most part, I don't think many of those plans offered on the marketplace are actually including things other than those. Also, cost-sharing reductions are limited to the essential health benefits. And again, we'll talk about the special provisions that American Indians and Alaska Natives have with regard to the cost-sharing reductions. The only plans that really don't offer essential health benefits and are offered on the marketplace and outside the marketplace are catastrophic plans. Catastrophic plans have extremely high deductibles and lower premiums, and they can only be sold to people who are under the age of 30, so young invincibles, or for people for whom coverage is otherwise unaffordable, and for people who recently lost their coverage because it didn't meet minimum requirements. You may have heard this past fall, a lot of people were losing insurance that they thought they could keep if they liked it. That was because those plans didn't include all of those essential health benefits. Now, the administration allowed the extension of those plans for an additional year, but this is another option for those folks as well. You don't get a tax credit to purchase a catastrophic plan. You don't get your cost sharing, including deductibles and copays, waived regardless of whether you're an American Indian or not if you purchase a catastrophic plan. The catastrophic plan, basically, all it does is prevent the tax penalty. And it provides, a very minimum level of care, including some preventative services. There are two types of plans on the exchange or marketplace. There are qualified health plans, which are, basically just insurance plans operating interstate. And then there are multi-state plans, which are operating in greater than 31 states. The only company that's currently offering a multi-state plan across this country is, of course, Blue Cross. As I said, American Indians and Alaska Natives do have special protections and provisions in the Affordable Care Act related to purchase of insurance on the marketplace or exchange. As I said, they're exempt from the penalty for being uninsured, but you need to apply for an exemption, and we're really going to dig deep on that. You're exempt from most cost sharing in exchange plans, and when I'm talking about cost sharing, I mean a deductible or a copay, not the actual cost of the premium. Those plans don't miss out on your deductible and copay, though. The federal government actually pays the cost sharing on behalf of the enrolled tribal member to the plan. And American Indians and Alaska Natives are able to enroll monthly. You may have seen a lot in the news about the fact that open enrollment ended on March 31st. But if you're an enrolled member of a tribe, you can enroll once a month. So you can enroll and disenroll and enroll and disenroll once every month as a part of this law. And you know, and I say enrolled member of a tribe because there's a little bit of a glitch in the law. There are some parts of the law that actually use the definition that IHS uses to determine whether you're Indian for the purposes of, you know, receiving services, and those are the Medicaid parts of the law. The exchange / marketplace and IRS parts of the law actually use a more strict definition of what it means to be Indian, and for that you need to be an enrolled member of the tribe or a shareholder in Alaska Native Corporation, which is kind of their version of being enrolled. We're working on fixing this. USAT and a number of organizations are working with Congress to fix that. But unfortunately, Congress doesn't seem to be wanting to do too much with regard to changing the law for a variety of reasons, as you can imagine. There are two plan variations for American Indians and Alaska Natives. There's the zero cost sharing, that means no deductibles, no copays ever, and then limited cost sharing, and those are kind of divided up based on your level of poverty. So for folks who are under 300% of poverty, that is, these are last year's numbers, that is $34,470 for an individual and $70,650 for a family of 4. There's no cost sharing anywhere that person seeks care. No copay, no deductible. No requirement for a referral from CHS. No requirement to stay in network. And of course, patients can always continue to receive care at Cherokee's Hospital. Limited cost sharing, two groups qualify for the limited cost sharing plans. Those are folks who are above 300% of poverty, and anybody who says, I'm probably, I'm more than likely above this threshold, say you make $500,000 or something like that. Somebody who doesn't request a determination of eligibility for health insurance programs would also qualify for the limited cost sharing. Now, limited cost sharing means zero cost sharing, no copays or deductibles for services provided at your Indian hospital or through CHS, but cost sharing would apply for other circumstances. So for those folks, you'll want to be giving them CHS referrals. Cost sharing limitations. As I said, cost sharing is limited to American Indians and Alaska Natives that are enrolled members of federally recognized tribes or Alaska Native shareholders. And this can be an issue for families that have some enrolled members and some, descendants. And kind of another nuance of the law is that everybody who's in a family on a family plan has to have the same cost sharing. So when you have mixed families, you're going to get the most benefit out of these plans, you have to separate enrolled members from those folks who may still be eligible for services at the hospital but are not enrolled. So those who are enrolled get these reduced cost sharing plans. Premium subsidies. American Indians and Alaska Natives have the same premium subsidies, like the same dollar amount as everyone else in the exchange. It's based on your modified adjusted gross income, and it's on a sliding scale up to, I said, 400% of federal poverty. The amount of premium subsidy is basically giving you enough money to purchase the second lowest cost, kind of the mid-level silver plan on the exchange, the amount that would make it affordable for you. And the premium subsidies, as I said, are delivered through the advance payment of tax credits. They're paid directly to your insurance company, and then there's a reconciliation of these payments at the end of the year through your taxes. And that's a little scary, and we're going to talk about that. So for 2014, the federal poverty guidelines are shown on your right. This is 100% of federal poverty. And so it's what the baseline for federal poverty is. Moving forward, this is more of what it looks like when you're talking about the various thresholds for eligibility under the law. So 138 looks like this, and that's the threshold for Medicaid. 250 is the threshold for some cost-sharing reductions for the general population. 300% is the threshold for our American Indian, Alaska Native, Enrolled tribal members to get completely zero cost-sharing in a plan, and then 400% is the threshold for receiving tax credits. So everybody below 400% gets a tax credit to help with the purchase of the cost of the plan.
Liz, if I could just
Sure.
Interject here. I want you to really pay attention to the 250 and 300% columns, because we are doing some analysis now on corporate sponsorship of groups that are within these income levels. And we think that this is where the biggest return on the investment is going to be. I'm going to talk to you a little bit more about that later on. But again, those families that fall from 300 down to the 138 and below is going to be, of course, Medicaid. But North Carolina, because North Carolina chose not to expand Medicaid up to 180, then we would be looking at everybody that's greater than 138 and less than 300. So just kind of keep those numbers in mind.
And as you can see, they're actually pretty generous, as you have more people in your household. 300% of poverty for a family of four is $71,000 a year. It's a pretty good opportunity when you're talking about actually having the federal government pay some of the cost of the premiums for the folks that you might consider sponsoring, and then paying the remainder of that cost. Another way to look at it is, annual premium limits by income level as a percentage to make it more affordable for you. So when you're at the very low income levels, the law says that you can only be charged 2% of your income for premiums. And what that looks like is somewhere around, less than $350. And that makes it a pretty good deal for tribes, because $350 won't get you an emergency room visit. $350 won't get you a surgery. When you're sponsoring folks, it's a lower investment up front and a pretty big payoff for your CHS program and for the tribe when you're doing third-party billing. The premium percentage limits go up to 9.5% of income, regardless of where you are on the income spectrum. You can never be charged more than 9.5% of your income for the cost of a premium, and that's for everybody. That's the threshold for making insurance affordable. Because enrolled members of tribes aren't subject to cost sharing, what you can do with your premium tax credit is you can stretch it further. You can choose a bronze plan that has lower premiums because it has higher copays and deductibles without worrying about those higher copays and deductibles. And so when you're thinking about tribal sponsorship, you always want to direct folks onto the bronze plan as long as they're enrolled members of the tribe, because they receive those cost-sharing benefits. Their premium, tax subsidy will actually stretch further than it will for other folks in the U.S. general population. There are definitely some barriers to American Indian and Alaska Native enrollment in insurance plans. Premiums, of course, are the biggest barrier because, when you're receiving care for no cost at the hospital, it's really difficult to explain to somebody you have to pay a premium for additional health care. Tribal sponsorship can and does eliminate this barrier. If folks, for the most part, don't want to pay a premium and the tribe pays it for them, they're much more likely to sign up for an insurance plan. Although, of course, you'll have some tribal members who don't want to provide the information to sign up for the plan. And that's something that you'll just have to recognize and kind of anticipate as well. IRS rules and regulations are difficult to understand. The payment of tax credits goes, to help you purchase your plan, goes straight to the insurance company. You never see that money, but at the end of the year, the IRS says, hey, you were either overpaid or underpaid in this tax credit. You either owe or get an additional tax credit, and that's a little scary. People who want to enroll in insurance plans on the marketplace actually have to file taxes. Unless their income is too low to file taxes legally, they have to file taxes. And, across Indian country, not a lot of folks do file taxes. And so one of the things that some tribes are doing is actually bringing in tax preparers to help people who may be filing taxes for the very first time. The reason for filing taxes is you have to prove your income, right? And the tax credit that will be given to you in advance of the purchase of your plan is based on what your projected income is for a given year, and they project this income using last year's income tax filing. They're pretty complex rules, and IRS is still kind of working those out. And so, IRS is kind of a major barrier to enrollment in plans. Another barrier is lack of insurance experience or knowledge. Some folks see the word deductible and copay and aren't sure what that means. They don't know what it means to have a premium. And so easing people into kind of insurance terminology and what having insurance requires of them is a barrier. Lack of motivation to enroll, as I said, and some of the exchange regulations are a little frightening. So when you're thinking about maybe doing tribal sponsorship or assisting with enrollment or both, you're going to want to plan and budget for that. You may see an uptick in people who are looking to be enrolled in the tribe. I don't know if your roles are open or closed, but you may see people who say, well, I have enough blood quantum to be enrolled. I want to be enrolled as a member of this tribe because you get all these special benefits, and because you need to prove either that you're an enrolled member or you're eligible for IHS to be able to be exempt from the law. You may want to budget for premium payments, and based on my conversations with Casey and with Angie Bradley, it seems like the tribe may be considering tribal sponsorship, and you're going to want to take a look at what the cost of that might be. Provider contracts. If you're going to be paying the cost of premiums for your tribal members, you want to be an in-network provider for that insurance company. Good advice is saying, tribal members, we're going to pay for this plan, this Blue Cross plan, and then becoming an in-network provider for that plan, so you can easily build that plan for all the services that you provide to your tribal members. You may want to have a communications plan. This is, kind of a new thing, although I do know that Cherokee has a pretty robust tribal sponsorship plan for Medicare Part B, and I know that you already do a lot of third-party billing, so I think that the infrastructure is there. But, how do you communicate this to tribal members who are under 300% of poverty? Casey and I were talking about how you're probably going to need to do income assessments for people to determine where they are on the poverty scale, and how do you do that? How do you tell tribal members that we need to know your income without it being offensive and without them reacting badly? You're probably going to want to budget for outreach and enrollment assistance as well, because the enrollment process is not perfect. We all know that, and so having people on site in person to be able to help people navigate this system is pretty crucial. And then, as I said, you may want to provide tax assistance to people who may not have previously filed taxes before. So, some states are not ready to start Medicaid expansion or operating their own marketplaces, but that can change. So here's where we're looking, here's what kind of the country looks like with regard to states operating their own marketplaces, exchanges on their own. As you can see, a good many USET states, Maine, North Carolina, South Carolina, Georgia, Florida, Alabama, Mississippi, and Louisiana are all not operating their own marketplaces for the most part. So, until your state chooses to do that, the federal government is going to be running things, and it's certainly a one-size-fits-all approach. Similar with Medicaid expansion, all of those states I just rattled off are also not expanding Medicaid, in spite of some efforts to do so. For example, the Maine state legislature has passed Medicaid expansion multiple times, and the governor keeps vetoing it. And up until now, they haven't had a veto-proof majority in their voting. So, I don't expect that North Carolina would expand Medicaid anytime soon, but it's certainly something to consider pushing for and keeping on, because there's a big benefit to tribes when you're able to enroll more folks in Medicaid. There's no upfront cost for the tribe, save the actual enrollment assistance costs. The federal government is encouraging states to implement the Affordable Care Act, and they can start in any year. So this brings us to some of our selected topics. I just want to quickly touch on the concept of tribal sponsorship, and to give you a little bit more information on how a tribe might go about that. Tribes benefit when their patients enroll in exchange plans because the tribe can bill for the services provided to everyone who has the insurance, or Medicaid, for example. Insurance then replaces the expenditures made by Contract Health, PRC. And this results in more revenue for the tribe, and more revenue means the tribe can provide more services for tribal members. It's as simple as that. Based on kind of projections, this is sort of a sample chart of what potential income and CHS savings for all uninsured users in a, kind of in a blind study given tribe would look like. Unfortunately, a lot of potential income and CHS savings comes from Medicaid expansion, and because North Carolina isn't expanding, you kind of just have to cut out this whole bar on the left. However, as you can see that even when you're purchasing insurance plans for people, you have major CHS savings and major potential income. I know that in preliminary studies, Cherokee may be looking at almost a 2-to-1 return on providing on purchasing insurance for folks under 300% of poverty. When we say tribal sponsorship, we mean the tribe pays a portion of premium for selected individuals. If you're a self-governance tribe, and I know that Cherokee is, federal funds can be used for this purpose. Unfortunately, all the direct service tribes would have to 638 their CHS programs in order to be able to use federal money to purchase insurance. So it's great when you're self-governance to be able to use those monies. The way that tribes are doing it, even though we had tried to make it kind of easier, we tried to encourage the federal government to build it into the website. Payments can come from one credit card or one bank account, and that's the best way to do it for tribal members. And just, you pay that bill every month, and make sure that those tribal members don't end up getting billed for their premiums. Unfortunately, the exchange kind of decides the rules for tribal sponsorship, and one thing, as I said, we were trying to work towards was the ability for tribes to do aggregate payments through the website, and unfortunately, that's not built into the website at the moment. So you can, based on your relationship with an insurer, you may be able to negotiate a better way to pay. But, kind of the best rudimentary way to pay is either by using one credit card or one bank account. Strategies include, selecting individuals to sponsor and not just sponsoring everybody. You could start with, say, people with diabetes or cancer, people are high CHS users, or folks who are on the older end of things. And then do kind of a monthly enrollment by progressively adding various demographics. As I said, you really want to look at bronze plans, which are lower premiums and higher copays, but because the copays are waived, that just stretches your money a lot further. You also want to take into account the fact that some people may not get any tax credits or subsidies. As I said, you want to work with one plan for sponsorship and become a network provider in that plan to easily bill for your services. One thing I wanted to mention was that USET is part of a coalition of area health boards and tribal organizations that have pooled some money that we've received from IHS to do outreach and education work on the Affordable Care Act. It's called TEOC. It's the Tribal Education and Outreach Consortium. We have a website where there's a ton of information about American Indians and Alaska Natives and the Affordable Care Act. It's called nativeexchange.org. And on that website, we have a tribal sponsorship page. And it's password protected, so I'm going to give you the password right now. It's native, the word native with a capital N, and the number 1. And you'll click on the health directors section of the website, and once you get past the password, you end up with a variety of choices, including a tribal sponsorship page. And on our tribal sponsorship page, we have a video about how the Fond du Lac ban in Minnesota actually was able to increase services and facilities in a big way by sponsoring Medicare Part D premiums for their members, and sort of what Fond du Lac plans to do under the Affordable Care Act. I know that they plan on sponsoring all their tribal members under 300% of poverty. It contains a case study that TEOC did on tribal sponsorship using 3 differently sized tribes, a small, a medium, and a large. 2 different scenarios for each tribe, so 2 different kind of demographic scenarios for who they might sponsor, and then produce some real numbers. Under the case studies, the tribes made between $1.77 and $5.99 for each dollar they invested in tribal sponsorship. And out of this case study, we were able to sort of develop a cost-benefit analysis, and that tool is available on our website as well. And moving forward, if you have any questions about what's on our website or looking for more information on tribal sponsorship, I'm more than happy to provide that, and I've already given a ton to Angie Bradley. So this brings us to IRS and the exchanges. IRS is obviously, it's an agency located within the Department of Treasury, and it has a number of roles under the Affordable Care Act, including calculating your modified adjusted gross income to determine where you fall on the federal poverty scale, the distribution of the advance payment of tax credits, so that money that helps you to purchase your insurance premium, the reconciliation of whether you were overpaid or underpaid in those tax credits at the end of the year, assessing tax penalties on individuals for not having insurance, making sure those who are eligible to be exempt from having to carry insurance get those exemptions, and then assessing the tax penalties on businesses for not providing insurance to their employees. When I say modified adjusted gross income, or MAGI, just so you know, it's calculated from your federal income tax, and it's used with your household size, so who you claim as a dependent on your taxes, to determine your percentage of federal poverty level. And your percentage of federal poverty level, as you've seen, determines your eligibility for Medicaid, Medicaid expansion, CHIP, the tax credits. For some of the American Indian, Alaska Native cost sharing exclusions, whether you're under 300% or over 300% means a lot when you're American Indian or Alaska Native. And then also the exemption from the tax penalty if you are too low income to be able to purchase a plan. As I said, advance payment of tax credits is how insurance premiums are subsidized. The rules are the same for American Indians and Alaska Natives as the general population. That money goes directly to the insurance company, and it can only be used for premiums for metallic plans offered through the exchanges or marketplaces, not for that catastrophic plan. One thing to note is that married couples must file jointly to access the tax credit. As you saw, the amount of the tax credit is calculated based on what it would cost you to purchase the second lowest cost silver plan on the exchange. And it's based on the percentage of your income to make the premiums affordable, sliding scale to cap individual premiums for that individual annually. Here's our handy dandy premium chart. Oh gosh. Okay. I'm going to roll through the IRS pretty quickly. I just want to touch on reconciliation very quickly. At the end of the year, the tax credits are recalculated based on what your actual income was over the course of that year. And those reconciliation rules are very complicated, and this is another reason why individuals who have who have received tax credits may need assistance from a tax preparer. Because your income may go up or down during the year, and that changes the tax credit amount that you're actually eligible for. If an income is higher than predicted, you may owe the IRS for the overpayment of the tax credit. This could be a political problem for tribes when tribal members find that they owe the IRS for the premium that you paid for them. If income is lower than predicted, you could get additional tax credits, and this could also be a financial problem for tribal sponsorship because you can't take that tax return back from somebody. And if the income tax is not filed, you can't qualify for the tax credit in the following year. One way to kind of prevent the reckoning at the end of the year is to select lower tax credit payments up front. The exchange application allows individuals to do this to avoid repaying the IRS, but this can be a problem for tribal sponsorship. We know that there's a tax penalty. And so I'm told that I only have a few minutes left, but I do want to touch on the exemptions from the law, as well as the benefits of the law. The individual mandate is pretty small for the 2014 tax year, but grows exponentially in 2016 and over the course of the time between 2014 and 2016. So how do you satisfy the individual mandate? If you already have insurance from your employer, from Medicare, from Medicaid, from the VA, you've satisfied the individual mandate and you have to do nothing. There'll be a box to check on your tax form. I have Medicare, I'm done. When you wish to not participate, when you're an American Indian who wishes not to participate or somebody else who wishes not to participate, you can apply for an exemption, and they can be granted by two different entities, either by the marketplace or by the IRS. And the big difference for us is that right now, according to law, the marketplace can only grant the exemption for IHS users who are not enrolled members. IRS can't do that. That's something that we're petitioning the IRS to do, and stay tuned on that. But for now, you can get an exemption from the marketplace if you're a member of the tribe, an enrolled member, or you're eligible for services from the tribe. There are a variety of other exemptions that you can apply for, including hardship exemptions. The IRS, as I said, can only currently grant the exemption for membership in a tribe and not for eligibility for IHS services. And the difference between that is really when you're applying through the marketplace, you're going to have to do that before tax time next year in 2015. If you're applying through the IRS, you can do it at tax time on your tax form. So the exemption rules are as follows. For American Indians and Alaska Natives who are enrolled in their tribe, they're eligible to receive all the special provisions, the cost sharing, the monthly enrollment from the marketplace if they choose to. Their exemption, if they choose not to participate, can be issued by the marketplace or the IRS. And this exemption is authorized permanently. You never have to renew it unless for some reason you're disenrolled from your tribe. For American Indians and Alaska Natives who are eligible to receive Indian Health Service benefits but are not enrolled, they're not eligible to receive any of the special provisions. So anybody who's a descendant that gets served cannot have access right now to those special provisions, the cost sharing, the monthly enrollment, etc. Their exemption can only be issued by the marketplace, so they're going to have to do it before tax time next year. But that could mean in the fall, that could mean in the winter. A lot of folks got a little bit panicked this year at tax time because there was some misinformation going around about whether or not you needed to have credible coverage this year, for 2013. And because, the law says that you don't have to have it until 2014, you really don't have to worry about exemptions until you're filling out your taxes next year. But their exemption is also authorized permanently with no renewal, with some limited exceptions. So when we're talking about the exemption for non-enrolled members, two regulations define who qualifies. This includes the Medicaid definition, so basically descendants who you serve but who are not eligible to be enrolled in the tribe. And then people who are not considered Indian who are eligible for IHS. So those are folks like spouses, if you have a resolution that allows you to serve spouses. Women who are pregnant with Indian children, adopted children, etc. the majority of people who are considered American Indian or Alaska Native, and some family members of Indians and Alaska Natives, are exempt from the tax penalty. So I'm going to skip around just a little bit. But when we're talking about applying for the exemption, and again, you really need to stress that they have to apply. I think a lot of folks in Indian country nationally understand that they're exempt. They don't understand that there's an additional step. So the federal government released the application on December 20th. It was later revised to make it easier in March. There's only a paper application for the exemption. We hope that a web-based application will someday be available, but we're not sure when. There are instructions available that detail, what sort of documentation you need to apply for the exemption, because it's not just filling out a form, it's also providing a photocopy of documentation that either proves you're enrolled in the tribe or proves that you're eligible for services. The application for enrolled members and for Indian healthcare eligibles was combined into one application, which is great because this helps facilitate the exemption process for mixed families, and we have a lot of mixed families. So you're going to fill out the form. You're going to attach the appropriate photocopies of documentation, and you're going to mail it in. And the actual exemption form says it'll take 1 to 2 weeks. In practice, we've seen it take quite a bit longer than that. We've also heard of the processing center calling folks and asking them for additional information and not being particularly forthcoming about who they are. So we've heard reports of people who have applied for exemptions and then gotten a call from the processing center asking for their Social Security number. And nobody wants to give their Social Security number over the phone. I wouldn't do that. So there are definitely a few bugs being worked out in the exemption process, and this is again why tribes may want to encourage their members to wait a few months before applying for the exemptions. But once you have the exemption, you get a certificate number. It's similar to like a Social Security number, and you can use that certificate number for your entire lifetime. You keep it with you for your whole lifetime. And one of the things that I'm saying is that it might be a good idea for folks, even if they know they're going to have health insurance, to apply for the exemption at some point, because you never know when you're going to have a gap in coverage, and that's just a little bit added insurance. I have employer-based insurance through USET, and I plan on applying myself. So the rest of the presentation kind of goes through some of the questions that folks will be asked when they're applying. And then I have a bunch of slides on what sort of documentation you need to attach when you do apply. For enrolled members, an enrollment card is good enough. But when we're talking about people who may not have enrollment cards or people who are eligible for services but aren't enrolled members, it gets a little stickier. But everything on these slides is on the official instructions for the exemption form. So again, when should individuals apply? You could encourage everybody to apply right now, but I just don't think it's worth it. You can assist beneficiaries if they need it, or you can encourage folks to postpone. A variety of reasons. Do I have time for questions?
Maybe one or two. Yeah. But we could, and we could follow up at another time. There's quite a few.
I apologize. There's quite a bit of information, and it's all interconnected, and so it can be difficult to present some and not the rest. Right. So I tried to pare it down as best I could, but I know I've taken up a lot of time. So if you have any questions, I'm happy to answer them. If you think of any later, you're more than welcome to contact me. I work for USET, and so I work for you.
Any questions for Liz? Perry?
Liz, that was you know your job very well. You know all the information, but there's no way the world could absorb even a portion of this. There's so many topics and so many different areas that dealt with so many different subjects. There were so many numbers thrown out there from this and from just in all these different areas. We needed to spend probably a couple of days like you did at USET to get a handle on this. But I know that I still have no idea whether or not, I don't know, it's an individual-based thing, or it's a good thing for the tribe, but I'm sure Casey's going to have his staff out there doing a good analysis of it and see what we need to do with people, and I think some individuals may have different individual requirements that they wouldn't have, that be unique to them, you know.
Certainly.
So even though they are, you know, we are enrolled members, there are also other circumstances surrounding that might I don't know. Anyway, thank you for your welcome.
You're welcome. Yeah, it's definitely a really nuanced law, and you know, we've had like really detailed questions from a variety of the tribes that USET serves, and you know, moving forward, that's something that myself and my training partner Liz Neptune and I are available to do. Is when you have a strange question about how it works in this particular situation, we do our best to answer that, and if we can't answer that, then we have contacts at the federal government who can help us. And I'm also more than happy to come back and do a long, meaty 2-day presentation if you like. But I don't think that would be any fun for the health board.
So, thank you, Liz. The most important thing, Mr. Chairman, that I wanted her to communicate were really three things. Number one, and of course by now everybody knows this, but the deadline for filing for the exemption has been extended. So all the panic that had originally started around this year's tax season went away. So obviously that's subsided. Number two, there will be methods for filing for the individual exemption. You know, for American Indians and Alaska Natives enrolled members of our tribe, they'll be able to just demonstrate proof of enrollment at the time that they file their taxes.
Yep.
That'll do it. They'll be able to go on the website if necessary and get their exemption form. And then for those folks who are descendants of the tribe or who are otherwise eligible for services in our healthcare system, we will be providing them some form of documentation that demonstrates that they're eligible, and then they will use that to file and get their online exemption. The Indian Health Service is working on a form letter that will be printed out of the RPMS system. That'll be forthcoming, and that'll be another way that we do it. So the lifetime exemption was the first thing I wanted her to kind of tee up with you. The second thing is I wanted her to start laying the foundation for this concept of tribal sponsorship or corporate sponsorship. We think that there is a great opportunity for this community in tribal sponsorship. We, as Liz mentioned, we've done some very early, very high-level analysis, and in certain populations, we think there could be a big return. We think we could spend $1 and get $2 worth of health care very easily for some populations. And the law is just remarkable for American Indians. We can enroll and disenroll every month. We can target populations to do this for. We can pick who and how much. So there's a lot of opportunities that we need to do some more analysis on and focus on, and then we'll bring you back some things to consider. So those were primarily the main thing. The third thing, I'm sorry, that I wanted to mention is that we are in the process in this community and in the hospital and other tribal programs of getting people certified and going through the training process to be navigators and to help. And we're trying to free up an office space at the hospital now so that we could hopefully have a full-time navigator there that could help meet with patients. Very similar to the way we do patient registration and the RCA process now. Hopefully we'll have navigators on site that can help and eventually be able to push that service out into the communities as well. We're not behind on this because, as Liz mentioned, we're not behind on the Indian exemption or the lifetime exemption, and we're certainly not behind on tribal sponsorships because the ability to make those corporate payments or those blanket payments is not really that's not really available at this time. So things are okay, we're not behind, and we're doing the planning to try to capitalize on these opportunities.
Okay, sure. Thank you. Trina, did you have a question?
Yes, Casey. Will you be working with the enrollment office?
Yes.
Okay.
Yes, very much. That's a necessity. Yeah.
Any other questions for Liz? Turn your mic on, Pam. Turn your mic on.
The extension date, how long is that for? Is it the deadline date?
There's no deadline
for
applying for the exemption because it's granted both retrospectively and prospectively for our population. Because, I mean, you know, if you're an enrolled member of a tribe, you've been an enrolled member of a tribe for your whole life, typically. Some tribes enroll at age of 18, but so, you know, it's an ongoing thing. You should have your exemption certificate number available when you need it, which is at tax time next year if you haven't had at least 9 months of coverage.
this number, the exempt number, Casey, are you going to have that just in case people lose that? Is that going to be part of the medical record, or?
You know, I don't know.
It might be helpful.
Yeah, it would be interesting if we could figure out a way, a field or something in RPMS where people could give that to us just like an insurance number or a policy number. I'll double check with the staff. The IT folks may already be working on that, but it would be good if we could help archive that for folks in some form or fashion.
Okay. Any other questions for Liz? Thanks, Liz.
Thank you so much, Mr. Chairman. Thank you.
For a good report.
Fabulous job, Liz. It's
thanks, Casey.
I'm hoping that this technology is digital. I don't think analog technology could keep up with Liz, as she covered about 2 days worth of material in 50 minutes. That was quite remarkable. I passed out a handout of the just an update on the new hospital project, something I thought folks would be interested in. I will try to, I'm happy to go over that, Mr. Chairman. We're at the top of the hour. I'm happy to go over it, or I can forego this presentation if that's your preference. And I also had a really brief update on mental health services, but it's not terribly pressing, and it's not anything that I have to do this morning, nor is it anything that needs action.
I guess looking at this report, and we've had a ton of information this morning, Casey, the new hospital report that you've handed out is kind of small. I don't know how many of you can see it, but I've had to get a pair of glasses. And I guess the most important question right now would be, are we on time and on budget?
And the answer is yes and yes.
Okay.
So we're on schedule and we're on budget.
I have a couple guests that Anthony, did you want to come up, or Punk, did you want to come up and address to the health board what maybe what the EMS is looking for?
Appreciate you letting us speak. I spoke with Casey, I spoke with you, Chairman Wolf, about EMS's concern for safety in the new LC site that will be at the new hospital. EMS is requesting that if ends would look in to maybe finding a site that's off premises, because where they have us located at now for the LZ, it's a big safety concern. We don't have enough room. It's a 50 by 50 pad, and as everybody knows, at any given time we can have 2 helicopters set down, you know, to what our needs are. 50-50, it's got a 90 by 90 clearance area, but it's going to be tight to put even one helicopter down on a 50 by 50 as far as the medevac.
Okay. Bill, do you have a...
You're talking about the new facility?
I am talking about the new facility, yes.
Casey, is there any room for expanding that, or is that a...
Actually, let me see if I can do this. I don't know if I can make this document camera work, but if I can, I might be able to show you what some of the challenges and limitations are. There we go. Okay. Okay, let me just try this if I can. So right now, because of the limitations with the site and how steep the grade is, you'll recall that you actually gave us a little bit more area on the back side of this, or on the top of the site, because the grade was so steep that we were going to have, you know, $250,000 to $500,000 worth of retaining walls, but Tribal Council supported providing us a little bit more land so that we could push back further and decrease the slope. So the parking that's going to be on the back side of the building is actually, you know, we're going to tear down that mountain. We're going to put the parking back there, and right now there's a strong possibility that parking is going to have to be terraced, again, because the slope is so steep. The helipad is tentatively planned for this area here. Okay, now the emergency room will be in this section of the building over here. with the loop road going around the perimeter of the property. And you can kind of see both with the slope and with our property line that it's incredibly constrained. Okay, so replacing the building on 10.5 acres has been, it's a remarkable challenge, and the designers are doing a great job with it. But unfortunately, this space here is really the most optimal space that we have for the helipad. Now, for servicing, for handling the traffic in the emergency room, that's probably adequate, and it's designed to industry specs for a single landing zone. But as Anthony pointed out, there are times when it's necessary for, multiple evacuations, if you will, or you have multiple patients and you need several aircraft to land. As he and I discussed, the majority of the time that that's the case, those patients are not coming through the hospital. The EMS is literally prepping and packaging those patients, and those patients are leaving the community and they are not coming through the hospital. And so for that reason, it's really not even necessary that a larger LZ be located on the hospital campus. It needs to be, it's more important that it be accessible and that it be safe and that it be more accessible to EMS. Okay.
So, Anthony, this one right here on the drawing, is that going to be sufficient just for the patients within the hospital?
The patients that we fly out from the hospital is very minimal. I'm not for sure on the grade. I've talked to several people, and they've kept us in the loop the best that they can, and we understand the restraint of not having the room. I'm just trying to save, if we're not going to be able to utilize that the way we have utilized our former LC, then if there's a place that we can relocate off of premises. There's a big safety issue with the cars. I'll be honest, I wouldn't want my wife's new Suburban sitting on the edge of that parking lot and UT come in and land. As everybody knows, when we bring patients in and they're critical and we do come into the hospital, there's a mass gathering of family, which there's nothing wrong with that. But it's a straight shot from the ER through the parking area. We don't have that mountain like we did have at the old one to keep people off of. They don't have enough security. There's no security, I guess, after 4:30 as far as maintenance, because maintenance is good to come out and help us with traffic and things of that nature. I'm just looking for financial savings for, if we're going to construct something, let's make it feasible and somewhere we can utilize it more appropriate for the community and for EMS and emergency care.
Okay, that's all I've got right now.
Albert and Perry.
Yes, Casey. Do we have a design complete?
Albert, turn your mic on.
Is there a design? Is the design complete for the hospital right now, or how far away are you from having a complete design with blueprints?
Yeah, we will have a footprint lock and the structural grid. All of that will be finished by the end of this month.
Okay.
So we're going to start releasing the site package, and I've got a schedule that I was prepared to show you. As you know, the mass excavation is happening now, and we're hoping to start on some of the foundational work in May.
Okay, thanks.
Perry.
I think we're early enough on in this project, though, still yet, where we can change to accommodate what we need to do to meet the needs of our people in an emergency situation like that. You know, if you go to Asheville Mission, they've got their helipad right next to the road. You know, there's a lot of vehicles and there's a lot of things around there. There's barriers around it they'll keep separating. And I think they got to cross the road with the patients when they come into the emergency room. I think we can come up with a design, some way like that, to accommodate what we have up here right now. You know, it's hard for me to picture it right now without actually seeing the layout, you know, from that picture and seeing the proximity to the vehicles that are parked there. But I think there's ways we can work this, and I think we just haven't put enough thought into it yet. I think we need to look at it, though, and look at some of these other facilities and see how they have accommodated the number of aircraft that they need to land at any given time. But there's not a whole lot of space that they use there, and they have what, 2, 3? I don't know how many helicopters they got there.
They have 2, and also they have to block off. They have to block off all the emergency entrance there when they land and bring the patient in.
Yeah.
That's what we're trying to get away from as far as the safety issue.
But if it comes down to it, though, we need to do whatever we need to do based upon the land that we have, and I think we need to give us a little more thought, though, Mr. Chairman, so see if Casey can come up with something a little bit better.
Right. Just to be clear, I don't think, and I'll need Anthony to correct me if I misunderstand him. I'm not under the impression that he's asking that we change necessarily this. He's laying the foundation that we probably need to consider a second LZ that is larger somewhere else, because having a large enough landing zone to accommodate the things that he's talking about. Number one, the amount of time that it actually involves the hospital is very minimal. And so therefore it doesn't necessarily need to be adjacent to or contiguous with hospital property. So I think, if I'm understanding you right, that's what he's saying. It's not that necessarily we need to change this. This is probably still okay for the real infrequent time that we fly a patient out of our ER. Okay, but in addition to this, we may need to consider another site somewhere else in the community, possibly even close to us, and it would be really good if we could get something, on this site close to us. Okay, but it doesn't appear that we're going to be able to fit anything inside this circle that we've got going on now.
Okay, all right. Since I think the groundwork has been laid for another landing zone somewhere else, Anthony, have you looked around the communities to see?
Well, I'm in agreement with Casey. We both looking at the map there further on down. I'm not quite sure what the tribe's intention is with that property, but that would be great. It would still be close. It's out of sight, out of mind. It's hopefully the gathering of the people when we have a helicopter come in will be similar to what we had, to where they're not going to, walk up right up to the LZ. Even at the temporary LZ that we have right now, when there's a helicopter set down, the parking lot fills in behind us, just being in the public's eye. People that don't have any reason other than they see a helicopter and they want to come up and see it. So that's all we're asking. Our biggest aspect is the safety, and then the where we can serve in the community and do what we need to do in a safe manner.
Okay, and I've asked you about the one across from the skate park, the lot next to the building there, and you said there's some power lines there that.
I think it's phone. I went back and looked. I think it's phone lines. That would be a great site if we could utilize it. We might have to get the power or the telephone lines and stuff moved or relocated, but we're up for any suggestions. I mean, obviously we're not going to have the budget to go out and buy a piece of property to do that, but I just want you to be aware. Me and Casey's on board. We have the same thought, but it would be great if we could access that lower part of that property down there.
Well, I think that would be an ideal place, it being close to the fire station and the EMS. You're usually calling for the fire department assistance when the helicopter's landing. So let's take a real hard look at that, and then we'll get with planning to see what we need to do to make that a landing zone, or see if it's feasible to do that.
Okay, thank you.
All right.
Thanks, Casey.
Thank you, Anthony. Mr. Chairman, before I conclude my comments, there is something about the hospital project that I want to talk to you about, and I'll try to be as brief as possible. The project is going very well. The team is functioning very well. Again, for now it's on time and it's on budget, and there are no concerns at the moment, except for this issue here. And if I could go back to the document camera. So you see on the document there is a section of land that's outlined here in blue, and this piece of land belongs to the tribe, and the substation is about 0.39 acres inside this little tract here. And then that piece of land then connects to more tribal land that's on the opposite side of Hospital Road. When the 10.5 acres was assigned to the hospital for this project, the boundary line was just drawn around that section of land. So it comes out here somewhere and then it comes straight down. We didn't know the extent of the Duke lease. We didn't know if it was more of this or if it was just the fence line or what. But the bottom line is we have a need for detention ponds. We're going to need to construct a couple of detention ponds for water runoff, etc. And the most ideal situation would be in this section of the map that you see right above the substation. We've talked to Duke Energy, and it's my understanding in the conversations with them, they have no concerns outside their fence. They really don't care what we do as long as we stay outside their fence. The chief has also expressed some interest in meeting with Duke and continuing the conversation about eventually moving that substation entirely. Okay, it just needs to move. It needs to be updated. I don't think anybody disagrees with that. What we'd like to propose is if leadership would consider adding this section of land to the property that's been assigned to the hospital, then that would allow us to do two things. Number one, we could put the detention pond on that property. Number two, the loop road, we'll be able to continue the loop road out here closer to the boundary. You can see that the loop road is right on the edge of the corner now. I'm sorry, I want to try to point that out. The loop road around the hospital is here, and then the corner of the property that I'm talking about is basically comes right up to the edge of the road. So that would give us a little bit more space to deal with the grading and that kind of thing. The other thing is it would give us some future expansion. It's already within the property that's been assigned to the hospital, and it would allow us some future expansion into this area. Perhaps if if the LZ didn't work out on Aquani Road, we could locate the LZ there. There's a lot of power lines through here, so I don't want to make that promise. But if the tribe would consider just making this available to us or adding it to the property that's assigned, and then perhaps if in the future if Duke moves the substation, then if we could have that whole section, that gives us a little bit more expansion capability, and it's within the existing boundary that you've already given us. Okay, because the existing boundary comes out this way and down to the road. Okay. Let me show you one more thing. Without that property, it's going to force us to try to do some other things with those two detention ponds. The only other two areas for the detention ponds are down here at the bottom of the map and then up here. There are two challenges with that. Down here at the bottom, if we have to use that area for detention, it's going to force us to remove all the trees. And right now, the plans, or this was actually designed so that there'd be a row of trees to shield the campus from the substation, okay, to give us a little bit of a barrier to the substation. But if we have to grub off all those trees and then build a detention pond down there, it's going to take away a little bit aesthetically. It's not the most optimal. And then obviously the second detention pond is going to be a challenge because it's going to be higher in elevation than the parking lot, and you can see from the contour lines it's very steep up there. Okay, so we have a plan, and if it's not pleasing to the tribe to add this section to the property that's been assigned, it's okay, we can work around it, but it's not the most ideal. The more ideal would be this option, which requires us to utilize a portion of that property that's still it's the tribe's.
Any comments in regards to this? Do you have a letter from Duke or anything other than verbal with regards to what they're using it for?
Yes, we do have some written communication with Duke, and Duke actually provided us their copy of the original lease, and the original lease included the right-of-ways for the transmission lines, and it gives us the exact I guess, the surveying of this 0.36 acres, and in those communication, they've told us that they really don't have any concerns outside of the fenced-in area. Okay.
Well, I guess we'll have to submit a resolution. Unless we make a move here, then we can endorse that in that resolution through the health board here.
Right. Certainly. And I guess what I was looking for at this point was to just tee up the conversation, maybe get some feedback from the health board about how you feel about it. And then if you're okay with it, then I would proceed to planning board and then a resolution. But I would want to do that based on some feedback from the health board first.
Go ahead, Bill.
What's the timeline, Casey, in needing to have this approved for those that detention pond?
It was my understanding from speaking with David Elliott yesterday that they're going to begin drawing the site, I guess, work with the idea that this is possible. But if we get a decision in, say, 60 days, it's not going to push us out too bad. We'll just change the drawings and we'll have to go to the less optimal option.
And has the chief mentioned when he's planning on having the initial talks with Duke? Has he?
He has not mentioned it yet. I'm not aware of any dates that he has, but he did ask us to pull some information together and some renderings, some elevations and that kind of thing to kind of help him explain to them what he's after. But the Duke property itself is really it's a separate issue for us, and I guess that's obvious. Regardless of whether Duke's there or not, it would still be more a better solution for us if we could get this little piece added to the assigned property.
Okay, that's all.
I don't have a problem with it. Of course, planning board. You want to make a move? I can't make a move, so if we make it move to send it to planning board and have discussions there.
I'll make a move.
Okay, got a move in a second. Send this to planning board. Trina, did you have a question before we?
Just a quick question, Casey, in regards to the detention ponds. What sizes do they have to be? Is there a protocol for that, or does it matter?
I don't know, Trina. Okay. I'm sorry, but we could get the civil engineers to come in and help us with that when it goes to planning board if necessary.
Okay, thank you.
Okay, got a move in a second to send this to planning board and get their feedback. So, all in favor? Unanimous by the members present. Anything else, Casey?
No, Mr. Chairman.
All right, we've got minutes from 3/19/2014. Has everybody had a move to approve those minutes? Second by Bill. All in favor? Unanimous by the members present. Next meeting is scheduled for May 21st, 2014. Is there any reason we can't move this to 10 o'clock meeting, Casey?
No.
I think we could be done by lunchtime if we set this back to 10 o'clock. So if you will put that on the calendars. I think Tommy might have help meeting, but I think she's usually here before 10.
I've got boys club. I'm usually here by this time.
Okay, by 10? Okay. We'll try to move that back to 10 for the next meeting. Thanks for coming aboard. Good to see everybody. Have a good Easter. Happy Easter.